Food for thought: explaining child malnutrition and what we should do. Section 1: Harms. In a cramped hospital ward in Jalalabad, Afghanistan, 18 toddlers lie silently across 7 beds, too weak from severe malnutrition to cry or move. Among them is 7-month-old Bibi Hajira, whose body has shrunk to the size of a newborn, and 1-year-old Asma, whose beautiful hazel eyes are wide open, barely blinking as she breathes heavily into the oxygen mask that obscures most of her face. Within an hour of the BBC's visit, Asma would become one of more than 700 children to die at this single hospital in just 6 months. Her mother, Nasiba, who has already buried 3 children, describes how her family's survival depends on her husband's sporadic day labor. This scene represents far more than isolated tragedy. Asma was one of 3.2 million Afghan children suffering from acute malnutrition, a disease that has been afflicting Afghanistan for decades as a result of war, extreme poverty, and the Taliban's takeover in 2021. Child malnutrition inflicts harm that extends far beyond immediate physical suffering, undermining the abilities that enable a good life across physical, cognitive, social, and economic dimensions. Part A: Defining the spectrum of nutritional deprivation. To understand the full impact of malnutrition, we must first clarify the different forms of nutritional deprivation. Hunger: the physical sensation of discomfort, pain, or weakness that is caused by a lack of food and triggers the desire to eat. When hunger becomes chronic and individuals lack consistent access to adequate nutrition, it leads to malnutrition. Malnutrition: deficiencies, excesses, or imbalances in a person's intake of energy and/or nutrients, encompassing both undernutrition and overweight, obesity, and diet-related non-communicable diseases. Chronic undernutrition, the insufficient intake of macronutrients and micronutrients sustained over an extended period, manifests in 4 distinct forms. Child stunting, measured as low height for age, indicates prolonged nutritional deprivation, often resulting in delayed mental development, poor school performance, and reduced intellectual capacity. Child wasting, measured as low weight for height, signals acute malnutrition and impairs immune system functioning, leading to increased severity and duration of, as well as susceptibility to, infectious diseases and an increased risk of death. Maternal underweight, characterized by low weight among women of reproductive age, is associated with higher incidence of intrauterine growth restriction, anemia, preterm birth, and increased perinatal mortality. Micronutrient deficiencies, the lack of essential vitamins and minerals, carry differing health consequences contingent on the specific nutrient, including adverse pregnancy outcomes and increased susceptibility to infectious diseases. Food insecurity, defined by the U.S. Department of Agriculture as a household-level economic and social condition of limited or uncertain access to adequate food. According to the World Food Program, food insecurity is understood as the absence of food security, access to enough safe and nutritious food for normal growth and development, and an active and healthy life. Food insecurity can be acute, referring to severe, short-term disruptions in access to food, and attributable to causes such as conflict and natural disasters, and chronic, describing persistent, long-term inability to meet dietary needs, typically rooted in structural poverty and inequality. Those experiencing food insecurity are especially vulnerable to hunger and lack stable, reliable access to food. Famine: widespread and systemic hunger that causes elevated mortality over a specific period. At the most extreme end of the spectrum, famine represents a complete breakdown of food systems, causing starvation and acute malnutrition on a mass scale. Unlike chronic hunger, famine is characterized by its intensity, temporal concentration, and mortality. These distinctions demonstrate that nutritional deprivation is not a single condition, but a spectrum of harms with different causes, severity, and consequences. These distinctions can help explain why some harms are immediate and visible, while others are slower and more likely to shape long-term health, development, and opportunity. Part B: The global scale of malnutrition. The crisis in Afghanistan is replicated on a global scale. The United Nations estimated that between 638 and 720 million people, or around 7.8 and 8.8% of the global population, faced hunger in 2024. Measured according to the Global Food Insecurity Experience Scale, approximately 2.3 billion people were estimated to be moderately or severely food insecure, 335 million more than 2019, before the COVID-19 pandemic. 2.6 billion were found to be unable to afford a healthy diet, with a significant contribution of poor diets to the global burden of malnutrition, diet-related non-communicable diseases, and mortality. Malnutrition manifests differently across regions, reflecting not just the severity, but the underlying food systems and inequalities. Within and across countries, malnutrition is concentrated among the poor, rural communities, and marginalized ethnic and social groups. The prevalence of the double burden of malnutrition has been rising globally and is favorably correlated with national economic development. 150.2 million children under 5 were stunted, 42.8 million were wasted, and 35.5 million were overweight, with Asia followed by Africa bearing the greatest burden across all three indicators. Part C. The multidimensional harms of malnutrition. Application of the capabilities approach to malnutrition reveals how it constitutes a deprivation of human freedom and functioning. The capabilities approach, developed by Amartya Sen and Martha Nussbaum, evaluates well-being by what people are able to do and become, the substantive freedoms to achieve functioning they have reason to value. According to Nussbaum, central capabilities are those that have central importance in any human life because they are implicated in everything that an individual plans and chooses. If we accept Nussbaum's 10 central capabilities as those that are truly central, malnutrition constitutes a multidimensional deprivation on the fronts of life, bodily health, senses, imagination and thought, emotions, and practical reason. According to Black et al., maternal and child undernutrition harms children's development, health, and productivity in adulthood. The first 1,000 days, from conception to a child's second birthday, are the most critical to establishing the foundations for healthy growth throughout life. Undernutrition during pregnancy and during the first 1,000 days are a major determinant of stunting, as well as subsequent obesity and non-communicable diseases in adulthood. After the age of 2, much of the damage from malnutrition becomes difficult or impossible to reverse because of the organization of the brain, immune system, and metabolic systems during those early periods. The mechanisms of harm operate through interconnected biological, developmental, and social pathways. Wells et al. Argue that early life malnutrition triggers lasting physiological changes through altered gene development, epigenetic modifications that affect gene expression across generations, and disruption of the gut microbiome. That is, early deprivation can shape the body in ways that persist long after food becomes available again. It can also produce so-called inappropriate adaptation. Fetuses adapt to scarcity in ways that become harmful when they later encounter abundant food. This explains how early malnutrition can contribute to metabolic syndrome, a cluster of 5 conditions including high blood glucose, low levels of high-density lipoprotein cholesterol in the blood, high levels of triglycerides in the blood, large waist circumference, and high blood pressure that increases the risk of diabetes and heart disease. Another major harm of malnutrition is its assault on cognitive development. Brown and Pollitt argue that malnutrition impairs intellectual development through multiple pathways. Malnutrition impairs cognitive development indirectly by reducing children's energy levels, causing them to withdraw from social interaction and environmental exploration, and delaying motor skill development like crawling and walking and slowing physical growth so that adults treat them as younger than their actual age, thus providing less cognitive stimulation. The Institute of Nutrition of Central America and Panama's Orient longitudinal study was a supplementary feeding trial in Guatemala, in which 4 rural villages were randomly assigned to receive different nutritional supplements between 1969 and 1977. 2 villages received Atoll, a high-protein, high-calorie supplement fortified with micronutrients, while the other 2 villages received Fresco, a low-protein, low-calorie sugary drink with no protein until fortification. Children consume the supplements daily at village feeding centers, with higher intake of protein and energy in the Atoll villages, especially during the first 3 years of life when nutritional needs are greatest. Follow-up studies in 1988 to 1989 and later on tracked cognitive performance, schooling, and adult outcomes for over 70% of participants. They found that Atoll recipients scored significantly higher on cognitive tests, completed more years of schooling, particularly women, and achieved better reading and occupational outcomes as adults, with the strongest effects among those from poor families. Thus, good early nutrition was found to act as a social equalizer, allowing poor children to perform cognitively at the same level as their more economically advantaged peers within their villages, and amplifying the benefits of education throughout life, whereas those who received inadequate education saw educational gains diminished. This means early nutrition can unlock the full value of education and opportunity that poverty otherwise blocks. Kim, Fleischer, and Sun examined the long-term health effects of fetal malnutrition on survivors of China's 1959 to 1961 Great Leap Forward famine, the deadliest famine in human history, causing an estimated 23 to 30 million excess deaths. The authors used data from the China Health and Retirement Longitudinal Study, a nationally representative survey of over 17,000 adults aged 45 and older conducted in 2014, focusing on rural-born individuals from 1954 to 1966, including famine cohorts born 1959 to 1961. They measured fetal famine exposure using province and year-specific death rates weighted by months in utero, creating a continuous proxy for malnutrition severity that exploited spatial and temporal variations across China's provinces. Controlling for birth year, month, province fixed effects, and parental education, they ran probit regressions on 6 outcomes: speech impediments, walking difficulties, vision impairment, stroke history, and cognitive errors on arithmetic/date recall tests. They found that a 1 standard deviation increase in fetal famine exposure raised the probability of speech impediments by 23%, walking difficulties by 16%, vision impairment by 5%, stroke by 23%, calculation errors by 4%, and recall errors by 2%, effects persisting over 50 years later. This demonstrates that prenatal malnutrition creates lifelong physical and cognitive impairments. Malnutrition harms central capabilities in ways that extend beyond physical illness. It threatens life through elevated mortality in infancy, childhood, and adult. It threatens bodily health through wasting, pregnancy complications, and chronic disease. It threatens senses, imagination, and thought by reducing memory, learning, and intellectual development. It threatens emotions because chronic hunger and illness can produce fear, stress, and despair. It threatens practical reason by damaging cognitive development. It threatens affiliation because illness, disability, and social stigma can isolate people from peers, institutions, and community life. As Dr. Ghani raises vis-a-vis Afghanistan's crisis, if large sections of our future generation are physically or mentally disabled as a result of malnutrition, how will our society be able to help them? Thus, malnutrition at scale degrades societies as well as individuals. Section 2. Social Structures. To understand why child malnutrition persists at what Salam et al. Describes as alarming rates globally despite dietary interventions and improvements during the last decade, we should understand social structures and why they resist change. According to Eastwood, a social structure is constituted by the ongoing, interdependent actions of multiple individuals, patterns that endure across time and, once established, both enable and constrain subsequent action. The concept of equilibrium from the field of game theory demonstrates how interdependence functions. Each player's strategy is shaped by the strategies of others, and the resulting pattern is self-reinforcing, stable precisely because each choice is optimal given the rest. Further, social structures are comprised of complex intra- and interlacings of rules, representations, and relationships. The social structures constituting child malnutrition can be sorted and described according to these 3 R's. Specifically, rules governing labor markets and land rights, representations that naturalize maternal blame, and relationships of gendered household authority work to concentrate malnutrition among the world's marginalized children. Part A. Rules, labor markets, and land rights. Rules are prescriptions and proscriptions on actions, formal and informal constraints. In the context of child malnutrition, 2 sets of rules are particularly consequential: those governing labor markets and those governing land rights. Kume et al.'s findings in rural Liberia illustrate how labor market rules produce malnutrition by structuring the economic options available to mothers. They conducted a mixed method study to examine the socio-demographic factors associated with the risk of severe acute malnutrition among children in rural southeastern Liberia, combining a survey of 100 Liberian mothers with 50 in-depth interviews of mothers and health workers at government health facilities. Kume et al. Found that mothers were less likely to have malnourished children if they earned over $50 monthly, were literate, or breastfed exclusively for 6 months. However, while nearly every interviewed mother was aware of recommended infant and young child feeding practices, unreliable jobs with low pay, forced separation in search of food and income, and return to school or vocational training in an attempt to escape poverty prevented compliance with these practices. In this way, the structure of the labor market, characterized by informal work, low wages, and absent maternity protections, constrain mothers' ability to feed their children adequately, regardless of their knowledge or intentions. Rule and Alderman's 2013 review of nutrition-sensitive interventions, published in The Lancet as part of a major series on maternal and child nutrition, synthesized evidence across agricultural programs, social safety nets, early childhood development, and schooling in low and middle-income countries. Among their findings is a country-level fixed effects analysis demonstrating that a 10% increase in GDP per person predicts only a 5.9% reduction in stunting, a rate of improvement significantly slower than the corresponding poverty reduction that the same income growth produces. That is, even as national economies grow and poverty technically declines, child malnutrition persists at stubbornly high rates. This finding contributes to the understanding that income growth alone does not dissolve the structures that concentrate malnutrition. However, a limitation of this analysis is that country-level GDP cannot capture distributional effects within countries, meaning the estimate likely understates the gap between economic growth and nutritional improvement for the poorest households. Land rights represent a second critical set of rules. While many countries ostensibly protect women's equal rights to land in their constitutions and legislations, marriage, divorce, and inheritance laws contradict these promises by discrimination against women, with enforcement failing due to deeply rooted traditional attitudes. Additionally, even when adequate laws are written, they are often poorly enforced by land administration bodies and courts that are dominated by men. In many low and middle income countries, formal land laws explicitly favor male ownership or inheritance. For example, land use and the transfer of land between generations is regulated by customary law in many traditional societies in sub-Saharan Africa, largely excluding women from property ownership and inheritance. In South Asia, even where statutory law nominally grants women inheritance rights, such as India's 2005 amendment to the Hindu Succession Act, social norms and family pressure routinely prevent women from asserting those rights in practice. As of 2015, only 10 to 20% of landowners in developing countries are women. Harris and Nisbet conduct a qualitative narrative review utilizing the United Nations Children's Fund's 1990 conceptual framework on the causes of child malnutrition and literature and development studies to identify a new framework for the basic determinants of malnutrition. Harris and Nisbet demonstrate that marginalization based on poverty, ethnicity, caste, and gender systematically excludes certain groups from essential resources and political voice. Where land tenure is insecure or legally inaccessible to women, smallholder farmers, or indigenous communities, households face chronic food insecurity regardless of their agricultural knowledge or effort. The rule, who may own, use, and inherit land, is a structural prescription that determines who can produce or access food. Rules are particularly important for equity due to their apparent neutrality. That is, a land registration requirement, a minimum wage law, or a formal employment contract does not prima facie discriminate. But when women, ethnic minorities, migrants, and the rural poor are systematically less able to comply with or benefit from these ostensibly neutral rules, the rules become instruments of exclusion. Part B. Representations. Controlling images of maternal failure. Representations are the shared categories through which people and things are cognitively sorted. One particular manifestation of representations is Collins' controlling images, stereotypical representations designed to justify and maintain systems of oppression by making social injustices appear natural and inevitable. These images function to disguise or mystify objective social relations rather than to reflect reality, redirecting attention away from structural causes and toward individual pathology. In the context of child malnutrition, a consequential controlling image is that of the negligent or ignorant mother. Hsiam and Susanto conducted a Prisma-guided literature review of 15 empirical studies published between 2016 and 2024, drawing from PubMed, Scopus, and Google Scholar, with studies focused primarily on Indonesia, but also including Uganda, Kenya, Nepal, Bangladesh, and Pakistan. The review synthesized qualitative and quantitative findings across these contexts to examine the social and cultural stigma surrounding children with stunting. Across multiple studies in the review, families with stunted children were routinely blamed for negligence, laziness, or poor care, framed as having failed to provide proper nutrition or attention to their children, regardless of their actual material means to do so. In a paper examining stigma as a barrier to treatment for acute child malnutrition in Kenya, Hsiam and Susanto found that this stigma functioned as a concrete barrier to healthcare access, as caregivers with acutely malnourished children were 3.64 times more likely to report shame as a barrier to treatment than caregivers of children with normal nutrition. That is, the social image of the negligent mother more than triples the likelihood that a caregiver will avoid seeking the treatment her child needs, directly worsening the child's condition. This controlling image performs ideological work precisely in Collins' sense. Kume et al.'s research directly challenges the empirical premise of the image, their data demonstrating that child malnutrition is a direct consequence of abject poverty, food insecurity, illiteracy, the precarious nature of formal work, and the lack of robust social protections. Part C. Relationships. Gendered household authority and the limits of agency. Relationships are recurrent patterns of interaction. In regard to child malnutrition, gendered household relationships are an influential structure. Kume et al. Found that married or partnered mothers had higher odds of having a malnourished child. However, Kume et al. Acknowledged that several studies from Africa have reported the opposite finding, suggesting that these relationships are context-specific and socio-culturally complex. Qualitative interviews revealed that married women whose spouses had extended families to support drained household resources, leaving less for the nuclear family and placing increased financial pressure on the women. Additionally, married women reported that gender power imbalances, including male partners controlling meal portions and feeding decisions, constrain their ability to make independent choices about child nutrition. Kume et al. Explore this dynamic further through the inverse relationship between maternal literacy and child malnutrition, with literacy purportedly conferring a form of gendered power, enabling mothers to maintain greater autonomy, access economic opportunities, and exercise decision-making authority within families and societies. That this association holds specifically for literacy, rather than educational attainment more broadly, suggests that quality, not quantity, of education is more significant for child nutrition and well-being, and the operative mechanism is practical agency, the ability to read nutritional labels, understand health advice from clinics, negotiate better wages in informal labor markets, access government services independently, and challenge male household authority over food allocation. Hisiam and Susanto's review corroborates and extends this finding at the relational level. Mothers are given primary caregiving responsibility but minimal decision-making power, with patriarchal norms preventing women from making independent decisions regarding child feeding. Additionally, social norms required mothers to follow food decisions made by older family members, even when those decisions were nutritionally suboptimal or harmful. For example, prohibiting the consumption of fish and eggs during pregnancy and breastfeeding due to traditional beliefs, which undermines both maternal and child health. These relational structures are reinforced by the rules discussed above and the controlling images that naturalize maternal blame. The result is a structural configuration in which the three R's are mutually reinforcing. A structural perspective is necessary for equity because it relocates the source of harm. Where a liability model of responsibility seeks to identify a specific perpetrator for a child's malnutrition, who, arguably, is typically a negligent mother, social structural analysis reveals that harm is produced by patterns no single actor authored or can unilaterally undo. According to Young, structural injustices are social harms that are induced by the structural processes that facilitate individual action. To that end, causation cannot be assigned to particular agents or decisions. A mother who cannot afford adequate food for her child is not the cause of her child's malnutrition in any morally straightforward sense. She is constrained by a labor market that only offers precarious, low-wage work, a legal system and cultural practices that deny her secure land rights, a household in which she has no decision-making authority, and representations that hold her solely responsible for outcomes she did not have the power to determine or alter. These structures are reproduced daily by the interdependent actions of employers, landlords, and policymakers that largely do not intend for her to be unable to feed her child, yet contribute to this result. Together, these structures form an equilibrium, in Eastwood's game-theoretic sense, that persists because each actor's choices are optimal given the choices of others. Disrupting that equilibrium requires reorganizing the rules, contesting the representations, and transforming the relationships through which scarcity is structured and harm is made to appear natural. Section 3. Recommendation. Any serious response to child malnutrition must target its structures rather than treating malnutrition as the result of isolated parental failure. A conditional cash transfer can ameliorate some of the harms caused by child malnutrition. My proposed cash transfer is responsive to feminist critiques of CCTs as coercive, stigmatizing, and time-burdening for women, which risk reinforcing the gendered structures demonstrated in the social structural analysis. By minimizing punitive conditionalities and engaging fathers in shared responsibility, the proposal aims to redistribute time, resources, and decision-making power rather than simply routing more obligations through mothers. In the ethical analysis that follows, I argue that, compared to the status quo and hard conditional cash transfer, the soft conditional cash transfer should be pursued on moral grounds. Part A. Recommendation. Social protection is a set of government-led policies and programs aimed at preventing or protecting all people against poverty, vulnerability, and social exclusion throughout their life course, with emphasis on vulnerable groups. Social protection comprises social assistance, labor market, and social insurance interventions. One form of social assistance intervention is cash transfer. Global health leaders and the World Health Organization have argued that some social protection interventions, including cash transfers, are policy tools for addressing the social determinants of health, to improve individual and population health and health equity in low and middle income countries. A cash transfer is a direct payment to recipients, as unconditional or conditional. An unconditional cash transfer provides payments to poor families without requiring specific behaviors, on the premise that recipients best understand their own needs and will spend or invest funds accordingly. Conversely, conditional cash transfers provide payments to poor families contingent on conditions specifying actions, such as ensuring children attend school or participate in regular health checkups. While research shows that people spend UCTs wisely, they tend to be less effective in regard to the promotion of specific policy goals, such as children's health. To that end, I advocate for a conditional cash transfer. CCTs were pioneered by low and middle income countries, those most affected by child malnutrition. CCTs can appear politically attractive in that they go beyond handouts and reward socially desirable behaviors. However, because they are designed to incentivize socially desirable behaviors, CCTs depend on an adequate supply of accessible, good quality education and health services. Thus, the cash transfer should be accompanied by public investment in primary health and nutrition services to ensure adequate supply and maintain quality services. Additionally, conditions should be sensitive to feasibility and practicality, avoiding requirements that impose unreasonable travel distances or transportation burdens on caregivers. Conditions could be waived when recipients demonstrate that services are too far, unsafe, or costly to reach. Specifically, I propose a national CCT program for households with children under 5 in the poorest income quintiles. Transfers would be higher during the first 1,000 days when nutrition is critical for brain development and growth. The program would be financed through progressive taxation, such as income, corporate, and capital taxes, that places the heaviest burden on the affluent. The reasoning is that progressive taxation has a higher positive impact on the poorest households, reducing overall income inequality. According to a report from the International Trade Union Confederation, an examination of the effects of financing social protection in Bangladesh, Colombia, Costa Rica, Georgia, Ghana, India, Rwanda, and Serbia found that regressive forms of taxation caused an additional rise in prices, reducing real income for all households. The program should be financed primarily through domestic taxation because a durable social protection policy should be rooted in the state's own public finance system rather than contingent on external generosity, such as the contributions from affluent countries. While external assistance from wealthier states or multilateral organizations could still serve as supplemental support, especially in the poorest countries, it should not be the main source of funding. The conditions attached to the transfer would be deliberately minimal and implemented as soft. Soft conditions are those in which non-compliance does not result in penalties. Hard conditions are the opposite. Recipients would be expected to bring children under 5 for quarterly growth monitoring and wait for age checks at the nearest public health facility, with waivers available for distances over 5 kilometers or lack of transportation. They would also be expected to attend at least 2 group nutrition counseling sessions per year covering infant and young child feeding practices, affordable complementary foods, and equitable sharing of care within households, as well as ensure children receive all age-appropriate vaccinations on the national immunization schedule, with documentation provided at health visits. These conditions should be understood primarily as a way to promote children's health. Education may still matter indirectly because schooling can strengthen long-term economic prospects. However, the immediate aim of the program is to protect child nutrition and development. An important feature is that non-compliance would not induce automatic suspension. Following soft conditionality models, missed appointments would generate outreach to understand barriers and offer support to resolve them. Clear, accessible grievance mechanisms would allow beneficiaries to contest errors or abuses, limiting the emergence of shadow conditions imposed by local officials, such as community service or attendance at political events. Part B. Practical Effectiveness. Bastera et al. Conducted a longitudinal, multi-country study that examined the impact of social protection coverage, including cash transfers, on child health outcomes across 46 low and middle-income countries from 2000 to 2001, analyzing 1,012 country-year observations using fixed effects Poisson models. The authors found that each 1 percentage point increase in social protection coverage was associated with reductions of 0.34% in under 5 mortality, 0.29% in stunting, and 0.14% in wasting, translating to reductions of 29%, 25%, and 13%, respectively, at full population coverage. Using counterfactual modeling, the authors estimated that social protection programs averted approximately 3.05 million under 5 deaths over the study period. Rastella et al. Employed a mixed ecological design to examine the effects of Brazil's Bolsa Familia program, the world's largest conditional cash transfer program, on under 5 mortality across 2,853 Brazilian municipalities from 2004 to 2009. Using panel data, the authors ran multivariable fixed effects negative binomial regression models, adjusting for socioeconomic covariates and the concurrent family health program. BFP coverage was categorized as low, intermediate, high, or consolidated, with consolidated defined as municipalities where more than 32% of the total population was enrolled in BFP and at least 100% of the eligible target population had been covered for 4 or more years. The authors found that under 5 mortality rate, overall and resulting from poverty-related causes, decreased as BFP coverage increased. Specifically, consolidated BFP coverage had the largest impact, with the strongest reductions observed in under 5 mortality from malnutrition and diarrhea. Higher BFP coverage was also associated with increased vaccination rates, greater prenatal care utilization, and reduced under 5 hospital admissions. Additionally, poor families enrolled in BFP increased food expenditure and improved food security in their households. Together, these findings suggest that a well-designed CCT can substantially reduce childhood mortality from malnutrition and other poverty-related causes in large, middle-income countries such as Brazil. Part C. Moral Permissibility. On T.M. Scanlon's contractualism, a policy is morally justified if and only if no one could reasonably reject it as the basis for informed, unforced general agreement. The assessment is comparative, in which we weigh the strengths of different people's complaints across feasible alternatives. Given the discussion thus far, I consider 3 courses of action: maintaining the status quo, adopting a hard conditional cash transfer, and implementing the soft conditional cash transfer described above. Status quo. Under current arrangements, millions of children experience preventable stunting, wasting, and early mortality because social structures constrain their caregivers' ability to secure sufficient nutritious food. Further, their caregivers confront impossible choices between working and feeding, and are often stigmatized as negligent when they cannot comply with idealized norms. Their complaints are extremely strong, especially given that these harms are preventable through policies that impose smaller burdens on better-off groups than the severe, lifelong losses borne by affected children. Hard conditional cash transfer. A hard conditional cash transfer would ameliorate some of the harms of child malnutrition at the expense of caregivers, typically mothers, requiring them to take on additional time and emotional burdens. Women recipients frequently bore the direct costs of conditionality. Additionally, non-compliance can occur for valid reasons. Yoshino et al. Identify non-attendance at health appointments occurring because recipients are not able to afford time off work, suggesting that conditionality may penalize women for the competing economic pressures of poverty itself. In practice, this design demands that women trade off income, rest, or other caregiving duties to maintain access to transfers. Thus, these women and their children have significant, reasonable complaints against this manifestation of CCTs. Soft conditional cash transfer. The proposed soft conditional design attempts to address the burdens imposed by conditionality while maintaining children's health goals. Because the travel and compliance burden documented by Yoshino et al. Is a consequence of conditionality, a soft conditional cash transfer, one in which recipients whose distance from facilities or lack of transportation exceeds a reasonable threshold are away from or granted modified attendance requirements, would mitigate this harm without abandoning the program's health goals. By inviting fathers and other household members to be involved, the program also responds to gendered household authority through participation rather than a direct challenge to patriarchal cultural norms, which poses moral objections. While caregivers and children still bear some burdens, clinic visits, group meetings, and modest reporting requirements, these are less than in a hard conditional cash transfer. Therefore, under this option, the reasonable complaints are weakest. Under the third proposal, the objections of those affected are the least strong. While children and caregivers still bear some burdens, these are less than the burden that would be imposed by hard conditional cash transfer. While affluent taxpayers and better-off groups may object to the required taxation, their complaints are weaker given the severity of malnutrition and the evidence of effectiveness. On this comparative basis, a soft conditional cash transfer is better than both the status quo and a hard conditional cash transfer. I find contractualism especially compelling in this context because it maintains the moral focus on the distribution of burdens, not solely on aggregate improvements in child health. By contrast, in its simplest argument, utilitarianism can justify policies that slightly improve outcomes for many while imposing severe burdens on a few. In the child malnutrition context, that could mean defending a coercive program because it raises average nutrition outcomes, even if it unfairly punishes women who are already constrained by poverty, distance, unpaid care work, or weak public services. Contractualism does not ignore outcomes, but asks whether those who carry the costs could reasonably reject the policy as unfair. In this sense, contractualism better captures the moral intuition that improving child nutrition is not enough if the policy secures that improvement by burdening those already affected. Part D. Conclusion. Social protection and, specifically, cash transfers have demonstrated capacity to lower child malnutrition and mortality in low and middle income countries. However, hard conditional programs risk reproducing coercive and unequal gender dynamics for the women who must meet their conditions. A national, progressive, and domestically financed soft conditional cash transfer targeted to the poorest households with young children, paired with investments in primary health and nutrition services and explicit efforts to redistribute caregiving responsibilities, aligns with the studied harms and structures of child malnutrition. Because it effectively reduces preventable harms while imposing the least objectionable burdens, I argue that this form of conditional cash transfer is the option that should be pursued on moral grounds.